Hello, everyone. Welcome to another medical podcast at MedSynapse, a platform dedicated to fostering knowledge exchange and sharing valuable insights in the field of medicine. I'm Dr. Nigar, your host for today's episode. We have the privilege of having a special guest, Dr. Jinan Abdullah, a highly esteemed medical oncologist, joining us. Dr. Jinan's extensive knowledge and experience in the field of oncology, particularly in sarcoma, makes her a valuable resource for our discussion, where we will be focusing on the topic of sarcoma. Dr. Jinan has a very impressive and notable background. She holds an MBBS in medicine and surgery from Kuwait University and obtained her training from the French Board of Medical Oncology at Sorbonne University, France. Currently, she is working in the lung and sarcoma unit in Kuwait, where she utilizes her expertise to provide specialized care to patients with sarcoma. In addition to her clinical work, Dr. Jinan has also authored notable publications, including The Role of Notch in Gastrointestinal Tumors, Rare Case of Osteoclastoma of the Liver, and being a co-author of Cancer in the Arab World. Her contributions to the medical literature further demonstrates her commitment to advancing knowledge in the field of oncology. We are incredibly grateful to have you, Dr. Jinan, with us
Thank
today.
you for having me.
Thank you. So let's begin with our interview session. Our first question is, what is sarcoma and what are some key characteristics of this type of cancer?
So when we talk about sarcoma, we tend to think of it as just a one single disease, and usually you find a very small chapter at the end of a book or at the end of an article about it. But if you really think about it, sarcoma is not one disease. It's actually more than 50 subtypes of the disease, each one of them with a very different characteristic, different genetic mutations, and different ways of being treated in the clinic. So when we talk about sarcomas, we're talking about tumors that are of mesenchymal origin, which means that they are tumors that arise either from the muscles, from the connective tissue, from the bones. It can also be from the fats, from the nerves, and from the blood vessels. This is only to talk about where the cells originate from, and then you can talk about the different locations. So it can occur in the head and neck region, it can occur in the trunks, the extremities, and then of course you have the molecular and the genetic subtypes. So we're really talking about something that is very heterogeneous, that you should not be treating it as one single disease in the clinic. The thing with sarcomas is that it's a very rare disease, around 1% of adult cancers. It's a little more common in childhood, so around 15% in childhood cancers. But when you have only 1%, that means that we have a very small number of patients to do the studies on. And then we also have very few doctors who are specialized in this field. And therefore, we tend to group them all together under one heading. But I think the only reason why we group them under one heading is because it's a rare disease. If it was more common, we would definitely have more people aware that it is not really one disease and it should not be treated as one disease.
Thank you so much, Dr. Jinan, for providing a clear understanding of this rare disease. And I believe that this highlights the importance of awareness and early detection of sarcoma. Now, moving to the next question, what are the main causes and risk factors of sarcoma?
Well, so we have risk factors that are specific to sarcoma. Of course, we have the risk factors that are common to all cancers, but specific to just sarcoma. Previous radiotherapy can cause sarcoma. So we have a lot of patients, for instance, who had a history of breast cancer, who are treated with radiotherapy locally, and then they come up to us after a few years with a sarcoma of the breast region. So previous radiation, exposure to some chemicals like herbicides or Agent Orange, and then in the childhood cancers, and those people who are around 30 to 40 years, you have some genetic syndromes that are related. So you have the most common that we see in our clinic is the familial adenomatous polyposis or Gardner syndrome, where people present with colorectal cancers and sarcomas. We also have a good number of cases of patients who are diagnosed with neurofibromatosis, who have a GIST. And again, coming up to the subtypes, a GIST in a patient with neurofibromatosis are not treated in the same way as patients who have GIST who do not have neurofibromatosis. So they are also molecularly very different. And then in the childhood, for doctors who treat pediatric cancers, you have other syndromes like Leigh-Fraumani, where a patient may present with breast cancer and with sarcomas. And you have Carney-Strateke's syndrome as well, where patients can present with paragangliomas in an autosomal dominant origin. But for me, as I treat adult cancers, I mainly see FAP and neurofibromatosis in the clinic.
Are all the different subtypes of sarcoma treated in the same way, or are there variations in the treatment approaches?
We were talking about how the 50 subtypes are all different. Our knowledge at the moment is quite scarce because of the way it is rare, because of the little research that we have at the moment compared to other cancers. But already with the little information that we have, it is not treated in the same way. So for example, if you have a tumor that is localized, so for example, say in the extremities, like the arms or the legs, we usually try to go for neoadjuvant chemotherapy to reduce the tumor size, to decrease mutilation of the patients, followed by surgery plus or minus radiotherapy. We do try to resect them in the local stages, but then even with that, the type of chemotherapy that we use as neoadjuvant or adjuvant is different. So you have cancers that are of bony origin, like osteosarcoma. We usually give them a basis of cisplatinum and methotrexate, whereas other tumors of mesenchymal origin, like liposarcoma, we would treat that with a chemotherapy based on doxorubicin. So there is a bit of a difference with what kind of chemotherapy you would use. And then there are certain tumors that are radiosensitive and others that are not. Some tumors will not respond at all to chemotherapy. So for example, a GIST, after all, is a type of sarcoma. It does not respond at all to chemotherapy. You'll have to treat it with targeted therapy. And then the targeted therapy is chosen according to the axonal mutations, whether the patient has history of neurofibromatosis or not. And then, of course, you have desmoid fibromatosis, which also does not respond very well to chemotherapy. It might respond a little bit, but we also tend to give more hormonal treatment for these kind of patients or surgical resection. So yes, it's a very wide range of diseases. People tend to think of it as, sarcoma, I'll just give them chemotherapy with doxorubicin. This is how most people think of it, but it's really not like that.
It's really fascinating to learn from the treatment approach of sarcoma. Like, it varies depending on so many factors. Yeah. So this personalized approach will ensure the patients receive most appropriate and effective.
That is true, yes.
Moving on to the next question, can sarcoma be treated effectively through surgery?
So with surgery, it is a very big topic in sarcoma because you really need a surgeon who is experienced in sarcoma to be able to resect sarcoma. It is not something that should be treated by a general surgeon. So yes, it can be treated and it's in the early stages, but this is a part where we really need to stress on the idea of multidisciplinary team and specialization. And the reason is that, say you have a patient who comes up to you with a mass in the lower limb, it looks round, firm, etc., and you have a surgeon who just goes and resects it. And then the histopathology comes back and tells you, this is sarcoma, this is not a lipoma, this is a cancerous disease. This means that maybe the surgeon didn't know the diagnosis and resected it before knowing the diagnosis, and the surgical approach is different. So the first thing is that surgeons should take a biopsy before resecting it. And this is something that we sometimes find a problem when you have a very big country that cannot cover up all the clinics. So patients end up going to other hospitals that might not be specialized. It can happen if you don't have enough awareness of the disease. Since it's a rare disease, you don't expect all surgeons to know about it. This is normal. So having patients referred to a specialized center, I think, is very important in this region, and taking a biopsy before the resection, because the biopsy can tell us a lot about how the resection should go. In general, when we take a biopsy from a patient with sarcoma, the biopsy should be a core biopsy with as little as possible disintegration of the tumor, because this is a tumor that can very easily disintegrate or cause seeding when you are maneuvering it. And that takes us back to the surgical part, your question about surgery. When a surgeon removes a sarcoma from the body, it needs to be removed entirely, altogether, so no rupture of the tumor. The capsule has to be intact. There has to be a safety margin, and of course with staging. So we have some patients who go to a private hospital, they get something removed, then they come back to us after the histopathology is out, and we realize upon staging that they had pulmonary metastases. They didn't know about it, and they had some part of their legs amputated, which is really a disaster, And this really comes back to the same notion of rare diseases require specialized care, because not everyone can know about it. I don't blame them for not knowing about it. I just think that awareness needs to be there. There needs to be specialized units for these doctors. So yes, sure, surgery can definitely treat the disease, but if it's not done properly, if there is a rupture of the tumor, if the tumor is disintegrated during the surgery, if it is not removed as a whole, if you get back the histopathology telling you that it's in fragments and the margins cannot be assessed, you've probably lost the patient. The patient will come back with metastases very soon. Once it is in the metastatic stages, we have very few lines of treatment because we don't have enough studies done on this tumor. So yes, usually when there is a patient with a tumor that looks like one big lesion increasing in size, usually you take a biopsy. Then if it is resecable entirely without the rupture, you can do surgery. And yes, you can cure the patients. But if there is a doubt in the possibility of doing the proper surgery with safety margins, no rupture of the capsule, then it needs to be discussed in a multidisciplinary team in order to reduce the size so that the surgery can be done more easily. Because there is where you can actually cure the patients. You don't want them to metastasize. Of course, there are other subtypes of sarcoma like desmoid fibromatosis, which do not metastasize. They just locally advance. They can be very mutilating. They can cause a lot of pain. These are usually treated surgically when possible, knowing that they will recur locally again. So the surgeons really have to check whether they can remove as much as possible, again, without rupturing the capsule. But in these cases, we're not really curing the disease. We know that it's going to come back, so we just try to do it to decrease the pain and to decrease the mutilation that the disease may cause.
It is very important to highlight it, because there can be surgeons who are not aware that the patient may be having sarcoma. So it's very important to be aware of this as well. Moving on to the next question. Does radiotherapy play a significant role in the treatment of sarcoma?
Definitely. So back to the surgical question. If the surgeon, say, for instance, removed the tumor and the margins were close, but not exactly clear, then radiotherapy would be very important so it can decrease the chances of local recurrence in that disease. But not only that, radiotherapy can also be used, for example, in patients like Ewing's sarcoma, where radiotherapy plays more of an integral role. We give them chemotherapy, we give them surgery, but even with that, we do prefer to give them radiotherapy to decrease the chances of local recurrence. Some tumors are radiosensitive, some of them are not, so you really need to look at the subtypes before you give them radiotherapy, but usually it plays a very significant role in decreasing the chances of local recurrence, but also sometimes if the tumor is causing pain and we're running out of options of treatment, then we try to give the patients radiotherapy just to decrease the pain. So yes, again, this is something that we discuss always with our radiotherapist colleagues before we take the decision. Definitely, yeah.
So I think that the use of radiotherapy is also important when surgery alone may not achieve complete eradication.
Yes, so usually in the meeting we have our surgeons, our radiotherapists, and our medical oncologist together, and we ask the surgeon, do you think you can actually remove the whole tumor, or do you think it's going to be impossible? And then we try to put our input, whether we can give chemotherapy or radiotherapy to decrease it, because some of the tumors will probably not need chemotherapy. They're not chemosensitive, so the radiotherapist will take role, or vice versa. Or if a surgeon tried to remove the tumor as much as possible and then found that there's a positive margin, then he will come back to the MDT and say, I removed everything that I could, but there are parts that I just simply cannot because, say for instance, there was an important vessel, or it was next to the ribs, some important vital organ was next to the tumor where he really had to remove it. Say the tumor was bleeding, it was causing pain, it was really big, it is not very chemosensitive, then he has to remove it, but then these positive margins will be dealt with by the radiotherapist as well.
As a medical oncologist, how do you approach the management of sarcoma cases?
So the first thing is the histopathology, because without the histopathology, we cannot really treat much. So in our center, what we do is we try to discuss each case of histopathology with the pathologist directly. If our histopathologists have a doubt about the diagnosis, sometimes they would actually spend their own money to send it to another center so that they can get an expert advice. And then depending on the tumor, so if it is a local tumor or oligometastatic, meaning it has only few metastases, say they have 1 or 2 lesions in the lung and a lesion in the legs. What I do in these cases is I usually discuss it with the surgeons, asking them whether if I give neoadjuvant chemotherapy and the tumor reduces in size, would they be able to resect it in the future so that I can go for a curative approach. If it is metastatic, there's no way we can resect it. Then it really depends on the subtype, so I discuss it with the histopathologist, and then it really depends. Some sarcomas are really aggressive, very fast growing, like the round blue cell tumors, embryonal tumors. These are tumors that I cannot wait for too long. Usually I start the treatment as soon as possible. Say within 1-2 weeks, I've already started the treatment, and it's usually treatment with a base of ifosfamide, vincristine, doxorubicin. It's a regimen where we alternate a 5-day regimen with a 2-day regimen every 2 weeks, basically. So we give VDC, vincristine, doxorubicin, ifosfamide, along with etoposide and ifosfamide alternating. And these patients are usually younger. So if you have a younger patient, of course, you have to refer them to a fertility clinic in the beginning. If you're going to give doxorubicin, you have to go for a cardiac ultrasound before you go for the chemotherapy so that you can survey the cardiac function. But then there are other types of tumors. Say I have one patient with a synovial tumor that is very, very slow growing. Over, say, 6 months, it has grown like, say, 1 centimeter, and the patient is completely asymptomatic. These patients, you can actually just monitor them and start giving them treatment when you think the symptoms are about to come in. So you really need to look at the subtype, and that's why I really stress on the fact that it is really a heterogeneous disease. You really need to look at the subtype before you start the treatment, because the fact that it's a rare disease and that we have very few researches done on it means that there's also less input regarding the types of treatment that we can give them. So most of the guidelines, when you look at them, we have like 3 guidelines for the basis of the chemotherapy, and then after that it's mainly off-label. So you really don't want to utilize all these lines of chemotherapy in the beginning. So if the patient has a very slow tumor, we kind of monitor them and only start them treatment when they are symptomatic. Otherwise, if it's a very aggressive tumor, you have to start right away. Now, if I run out of all the chemotherapy available and the patient is still there, the tumor is aggressive, then what we're doing at the moment is we go for NGS, next generational sequencing, and we try to look for any targeted treatments. We already have some targeted treatments that we use for a variety of cancers, except for, say, for example, pazopanib can work in most sarcomas except for liposarcomas, for example. So you try to use pazopanib. Otherwise, you look for these genetic mutations, and in some hospitals, usually you need a tertiary center to do that. You can use immunotherapy if the microsatellite instability is there. So it has to be an MMR high patient. So usually, very broadly, if it is a patient who has a metastatic bony disease, we go for cisplatin-based methotrexate. If it is other types of mesenchymal, we go for doxorubicin ifosfamide, plus or minus vincristine for patients who have an embryonal tumor. The second line usually is also chemotherapy, so trabectedin. In our center, we used gemcitabine docetaxel simply because we have more experience with it, but the guidelines do recommend trabectedin. And then after that, you really need to go for NGSing. You need to check for the microsatellite instability and check whether targeted treatments can be used.
Also, this multidisciplinary approach of the sarcoma care stresses on the importance of personalized approach to optimize the patient outcomes from our understanding.
Yes, well, yeah, it's also because, we're talking about 1% of adult cancers representing 50 types of heterogeneous tumors. So every individual, every doctor, even I as a sarcoma specialist, might not know everything that my colleagues know. I might not be able to assess the surgical margins or the ability for surgery or radiotherapy. Or maybe I've seen more, say, Ewing sarcoma than contour sarcoma, and my colleague has seen the opposite. So one thing is, when it's a rare disease, you do need to make sure that you know what you're doing before you do it. No matter how specialized you are, you will come up with a case that you've never seen before, a case that has very few articles in the literature, and therefore you need to get as many opinions as possible to be able to cure the patient if possible. And the other reason is that, as you said, there is personalized treatment at the moment. So we don't want to just rush in and give the same treatment for everyone,
Absolutely. Thank you so much, Dr. Jinan. Now, moving on, our next question brings us to the topic of immunotherapy. So in the recent years, there has been a lot of data about the role of immunotherapy and genetic profiling in cancer treatment. Do these advancements have any role in the treatment of sarcoma?
So yeah, definitely this happens when you have a patient, for instance, who has a stage 4. So we're not talking about the local stages where it is curative. At the moment, these drugs have a palliative role of decreasing the incidence of recurrence, or basically just controlling the disease. And it happens after we have exhausted all the lines of chemotherapy that we have at the moment, which I spoke about, doxorubicin, trabectedin, etc. Now, with these, you really have to look into the histopathology and check whether there is microsatellite instability, or whether there is a targeted hotspot mutation, basically. At the moment, the main things that we use are NTRK mutations, pembrolizumab if there is an MSI, and pazopanib we use it in a more regular basis. You don't need to do NGS for pazopanib. I must say that in general, it is in more advanced centers that have more patients, more centralized units that are going for this at the moment, but I think it will come in the coming years. Basically, what we do at the moment is, if we have a patient who is still in a good general condition, still able to walk, he's not cachextic, for example, he has a stage 4 disease, we have exhausted all their lines of chemotherapy, then yes, we will check for the microsatellite instability and not the PD-L1. At the moment, we don't have any kind of evidence on the basis of PD-L1 for sarcoma, so we only use the MMR status of the tumor, as well as the NGS. And then the NGS, we try our best to use the targeted treatment, even if it's off-label. Usually we validate it because of the fact that this disease is rare, usually touching younger people who are still in a good condition. So yeah, that's the role at the moment. It comes up in the palliative roles and the later lines, but we do get these patients, yes.
Thank you, Doctor, for shedding light on the role of immunotherapy and genetic profiling in sarcoma treatment. Now, our final question focuses on patient outcomes. What strategies can we do to improve the outcomes of patients with sarcoma?
Yeah, that's a good question, and I think this is the reason why I chose sarcoma as the topic. Because I think that the reason why we are unable to treat sarcoma as well as we treat other types of tumors like breast cancer or lung cancer is simply because of the low number of cases. I don't think that it is impossible for us to improve the outcome simply if we had more patients, basically. This can be really good if you have a very big country with, say, one big hospital where patients can go to. But if you have very small countries right next to each other, and every single country with only, say, a population of 2 million is trying to get the expertise, you will never get that expertise because you just simply have a smaller number of population with a smaller number of patients. So I think for us, for example, in Kuwait is a very small country. We only have one hospital at the moment, one unit. I'm treating sarcoma with only 4 other doctors. We have very few patients coming up. So I think what is the best thing to do is have more centralized units. And now we have a lot of people who are learning to collect databases more efficiently than we used to. I think the best way is to have a database in the region. So for instance, we can start, for example, in the Middle East, where all the countries from the Middle East can collect their own data. And then slowly we can increase it to the North African, the other Arab regions. The bigger the area, the harder it is to collect all the data, but the more efficient it will be. Once we have all these patients coming up, inserting their data, we will slowly start to notice the patterns of each subtype of the disease. So say, for instance, in Kuwait, in 1 year, say we have 5 cases of Ewing sarcoma, but if we put UAE, Qatar, Oman, and then the North African countries, then we'll have a lot more Ewing sarcoma cases. You'll have a lot more specialists inputting their information. And then there is where we can actually start noticing differences. There is when we can even have like a specialized unit in the region. So any patient diagnosed with sarcoma, for example, in Kuwait, in Qatar, etc., can go to one regional hospital where all the countries are collectively cooperating to bring only the specialized doctors, specialized surgeons, specialized radiotherapists in that one center. And there, I think we can start talking about efficiency in surgery, chemotherapy, NGSing, knowing where to look at the target mutations. I think it can be initially very expensive to do, but on the long run, I think it can be a very efficient way of treating cases well and decreasing the cost. So I think it's a benefit for all of them. As I told you, when you look into the internet, there are very few studies, very little data on how to treat rare cases like osteoclastoma. We've only seen one. When we looked into the literature, there was maybe like 3 articles in the entire internet. So imagine if we had all these data, putting it into one study where we can see all together all the sarcoma specialists, each one of them trying to input their information. So yeah, my suggestion would be just to allow the Middle East to cooperate and then slowly increase that region to involve other regions. We will definitely need IT technicians, statisticians, all the people who know how to insert databases properly. And then, of course, you will need someone who can link the pathology lab with the data so that when we do the NGS of patients, it can go directly into the computer and you can have all the database of all the genetics of all the patients living in the Middle East who have sarcoma. And then you will have only, say, a team of sarcoma surgeons who know exactly what to look for when they are treating these patients. And this is the main reason why I chose sarcoma. I think this is something that we can improve. There is room for improvement. We do not really need to rely on outer studies. We can actually start it in our own region. It just needs a little input and to choose one place where all the sarcoma specialists can work, basically.
We truly appreciate your time and expertise in discussing sarcoma today. Your dedication to the field and contributions to improving sarcoma treatment are truly commendable.
Thank you so much. Thanks for having me.
Thank you.
Right.
And that concludes today's episode of Medical Podcast. We hope you found this discussion informative and insightful. Stay connected with MedSynapse, your trusted platform for medical knowledge and information, where we strive to bring you the latest advancements and expertise in the field of medicine. Stay tuned for more enriching discussions. Until next time, goodbye.
Thank you. Bye-bye.